officer at a community trade union, and thank you. And I want to thank all of you for coming along and for all our fantastic speakers that we're going to hear from in just a moment. But before I start, I just want to make the most important comment, which is about the drinks. We apologize that they arrived in a bit of a delay, but please help yourself, just if you can do it quietly. That would be much appreciated. I'm sure you can all do that. I'll be very short. I just want to thank SME for Labor and LWN for being our partners, and it's really great to be with them at this event. Specifically, I want to thank Ibrahim and Jonathan from SME for Labor, and Claire, Jane, and Kat for bearing with us in the last few weeks and all the logistics around this. But I think we ended up with a really good room and a fantastic panel, so all great. I want to thank our speakers, and I just want to say for community that for us, this issue that the panel is going to discuss, women's health, this is not a niche, this is not a personal issue, it's not just a women's issue, this is a health issue, it's a public issue, it's a workplace issue, and as far as we're concerned, community, that makes it a trade union issue, which is why. Thank you very much, and that's why we are very proud to support this event, and I'll hand it over now to our chair, Daisy. Over to you.
Thank you so much, Maya, and welcome everybody. It's fantastic to see the great audience. I'm really excited to be here. My name is Adebisi, but I always say that my name is as easy as ABC because you can just call me BC. So that's BISI. From menopause to mental health to maternity, when will women be heard in healthcare? This topic is really important, and I have lived experiences so many I don't even know where to start. But I want to tell you a true story, and this is something that is really quite emotional for me. A few years ago, I was in so much pain, like excruciating pain. I could literally feel the pain from my head to my toes. And so, I was 6 months pregnant, and I rang the hospital, like most of us would do if we're in that sort of situation. Most of us women would do. And the person who picked up the phone immediately said, you can't be in pain if you're able to speak coherently. And I said, I'm actually in serious pain right now. I really need help. And she insisted that I was not in pain. And I said, I think I'm in labor. I think my baby might be in trouble. And she insisted that I didn't sound like somebody who needed help. I cried, I begged, nothing. A few hours after that, we had to ring an ambulance because my waters popped. And my baby had to be born via an emergency cesarean section. This was 13 years ago, approximately, and my son today is living with the consequence of the simple fact that somebody ought to have listened to me. I understood my body. I knew I was in pain, even though I wasn't swearing, but I was in pain. And, every day when I see him struggle with the speech and language therapy and the fact that I was brain damaged at birth, I constantly remember that if someone listened to me, we would not be in this situation. So this subject, as you can imagine, is very emotional for me. So a few more facts about me, for those who haven't met me before. A member of the executive committee, a mom to 2 children with special needs. I still keep saying that, but yeah, I've just lost one. I run a business, which I'm really passionate about because we support parents who want to create memories with their little ones. So my brand is the best-selling baby wearing brand in the whole of the United Kingdom. And this was a business that I started right from home. As a result of my special needs parenting, my both children having these very complex disabilities, I started support groups to bring parents, especially mothers who have children with various forms, I mean, it's a spectrum of disabilities. And I also had to put my experience into a series of books, mainly because I wanted to give a voice to my anger, so to speak. So I've written 3 books: Incubating Hope, Befriending Adversity, and I Fly. I'm a recipient of the prestigious DFID scholarship, a graduate of the University of Nottingham. I'm currently a local councillor in St. Helens, the first councillor of African descent. So far, fingers crossed we'll have more. Thank you, sisters. I was elected to the LWN in 2020, so it's fantastic to be your chair tonight. I promise you that tonight is going to be memorable, inspirational, and I think emotional as well. So we have a fantastic lineup, as you can see. Great women, great leaders. So I'm going to be introducing our speakers very soon, and our speakers are going to be dropping gems that I call tweetables. So please support me by making these events as memorable as possible. Women have been screaming for years that we want to be heard. So tonight, or this evening rather, the world must hear us. So if there's anything that resonates with you, any of our speakers say anything, please feel free to tweet, and I'll tell you the hashtags that you'll be using very soon. So we have Claire Murphy. Let's go and give our sisters a wave. Hello. Thank you. Taiwo, please wave. Thank you. Elizabeth Carr Mills.
Yep.
Sorry, Taiwo Owatemi MP. Apologies. Elizabeth Carr Mills. Carr Ellis, apologies. I typed that wrongly. Okay. Okay, we don't have Dr. Rosanna here, so I have Ashley.
Hello.
We have Belle Ribeiro Adi MP. Hi. So I'm going to be telling you a bit more about our fantastic lineup of speakers later on. But first of all, I would like to remind sisters that as with most of all our LWN events, whether virtual or face-to-face, we usually encourage sisterly, polite sort of ambience. We want this event to be a safe space for all sisters. So we will not tolerate any abusive or inappropriate language. If there is a breach, we will have to remove participants. If we then feel that our safe space will be compromised, we will have to shut down these events at short notice. Hopefully that won't happen. A few words about Labour Women's Network. For those who have never heard about us, LWN. Labour Women's Network was founded 34 years ago to secure women's equality in the Labour Party. We are the only official women's affiliate to the Labour Party, a membership organization and socialist society. Our membership figures are currently at a record high. Through LWN Political School and the Joe Cotterman Leadership Program, we train and empower women to change the culture of their local parties, stand for public office, and be ready to lead. We are proud to have trained a third of the current Women's Parliamentary Labour Party and half the women in the shadow cabinets. Amazing. As well as women at all levels of office across the country. LWN campaigned for necessary changes in the Labour Party. Practice, policies, culture with recent successes, including making labour selection shorter, cheaper, and making Labour's events safer for women. We're also campaigning to embed hybrid working long-term in the Labour's practice as we push to keep the good stuff from pandemic and to diffuse abuse, and these are our campaigns, against women in public office. LWN believe in sisterhood, no matter your shade of red. And we aim to bring diverse Labour women together to make our voices heard collectively. Sisters, I really want to encourage you to join the Labour Women's Network as members. I'd like to thank our partners for this evening, and we have the Community Union. You've actually heard from Maya at the beginning. And I'd also like to thank SME for Labour for their generous support. Please, can you give our partners an applause? Thank you. So our goals for this evening are as follows. We would like to explore why women feel increasingly unheard and insufficiently listened to in healthcare structures. Are British healthcare systems institutionally sexist and racist? The revolutions which are beginning to take place to transform these, and the work that our panelists are going to do to make a change around these issues. We're also looking to explore the issues around which women have been particularly silenced or sidelined by the system, e.g., mental health, or reproductive rights, Black maternity, mortality. I'm sure that some of you watched that very, very famous documentary that actually went viral about the fact that more Black women are likely to die while they're pregnant, and also menopause as well. And some of our panelists, if they're comfortable, will be sharing personal experiences on this subject as well. And the last point that we'll be looking to explore this evening is what fundamental shift in power or approach do we need to make a women-led healthcare a reality? So, like I said earlier on, sisters, please tweet and let's shape Twitter, possible, or Facebook. Our hashtags are Lab22. We also have the Women's Health. So it's Women's Health. And if possible, can you tag the following handles as well? At Labour Women's Net, at Community Union, at SME for Labour, at A. Oshundeko, at Bell Ribero Adi, at B. Pass 1968, at Taiwo Owatemi, at Lizzie Carr Ellis, at Dr. Rosanna. Dr. Rosanna will be here soon, by the way. Well, this event, sisters, is currently live streamed via our LWN Facebook page, so we'll be welcoming questions from our virtual attendees as well. During our question and answer session, you all will be welcome to participate. And Claire, will you kindly help us with the timekeeping? Thank you. So I mentioned that we have such an exciting lineup of panelists, and I'll be telling you a bit more about each of them briefly. We have Claire Murphy, the CEO of BPAS. Claire is the Chief Executive of the British Pregnancy Advisory Service, BPAS, a charity which delivers reproductive healthcare services to women each year across the UK and campaigns for women's access to evidence-based information and care to enable them to exercise their reproductive choices. Their strapline is trusting women to decide. Claire is also a board member of the European Consortium on Emergency Contraception and believes passionately in removing the barriers that women face to access contraception. Prior to joining BPAS, Claire was a health journalist at the BBC. Please can you clap for Claire? Fantastic bio. Thank you so much, sisters. We have Taiwo Owatemi MP. Taiwo is the MP for Coventry North, and she was elected in 2019. Until recently, she served as Shadow Minister for Women and Equalities, having previously been PPS and then Shadow Home Secretary. Before entering Parliament, Taiwo worked as a pharmacist, specializing in cancer and palliative care before being elected to Parliament. And she is a member of the All-Party Parliamentary Group on Pharmacy. Taiwo chairs the All-Party Parliamentary Group on Investment Management and is also a member of the All-Party Parliamentary Groups on Nigeria, Knife Crime, on Thalassemia and the West Midlands. Please give a round of applause to Taiwo. Thank you. We have Elizabeth Carr Ellis. I pronounced that correctly this time. Menopause campaigner. Elizabeth is an educator, a journalist, editor, campaigner, writer, whose own experience of menopause spurred her to write on the 50cents.net, a guide to help women through this time of life. Professionally, Elizabeth has worked at some UK top publications, including the Sunday Herald, the Week.co.uk, Edinburgh Evening News. She was also a monthly columnist and feature writer for Spain magazine and has written for such diverse outlets such as The Guardian, The Week Junior, and other both in the UK and in Spain. Fantastic. Please can we clap for Elizabeth? Thank you. I'm going to be introducing Dr. Rosanna later because she's yet to join us. So I'm going to be introducing Ashley now. Ashley is my fellow Labour Women's Net executive, brilliant woman. Ashley is a cancer survivor, and like I said, she has a lived experience, so this subject is really dear to her heart as well. We have Belle Ribeiro Adi. I hope I pronounced your name correctly. Fantastic. Thank you, sister. So she has represented her own constituency of Streatham as a Labour MP since 2019 general election. She was born and raised in Brixton Hill. Belle is she is a dedicated feminist, anti-racist and trade unionist who currently sits on the Women and Equalities Committee in Parliament. She also chairs the APPG on the Black maternal health and the APPG on African reparations. Belle cut her teeth in student politics, serving as a National Black Student Officer. During her time in Parliament, Belle has been a strong voice for equalities as she has called on the UK to make reparations to the Global South in her maiden speech. Very impressive. Consistently raising health equalities and fighting for a fair and humane immigration system. Belle, please can we clap for her? Thank you. I'm going to be starting with Belle. She's going to be the first of our panelists to actually make a contribution because I'm aware that Belle is going to be leading shortly, right? Okay, so that's 7 minutes, please. Please wink if you think we're going to book. Thank you.
Well, thank you very much for having me today. I'm really sorry that I have to rush off, and I'm really pleased to be joining you for this important event. I'm pleased that it's something that we're discussing at this conference that we're giving women's health issues for really vital short time. Now, I think it's really fair to say that for women accessing healthcare services can be really infuriating and often exhausting, and as a black woman that can be doubling so, because although in some ways we've managed to move from blaming hysteria and for any and every woman's health issue, we've actually made much more progress in this area, and that's due a lot to women like you. So from a lack of research, lack of understanding, a lack of compassion and a general unwillingness to listen, as women we find ourselves facing barrier after barrier when accessing basic healthcare services. We find ourselves being turned away from GPs, having our concerns dismissed. We raise complex health issues that are often given a solution, take this pill, go to a pain clinic, as a magical one-size-fits-all healthcare solution. And a lack of research means that our concerns are dismissed as minor problems when they're often signs of more severe illness. So from endometriosis to menopause, there are serious issues that affect large numbers in this population that might go ignored. Now, the barriers that we face can range from irritating to life-threatening, and for black women, the barriers are compounded by racial biases in our healthcare system and often to a dangerous level. And I want to talk about a bit about the work that I do in the Party Parliamentary Group for Black Maternal Health. If you're a white woman, then the UK is actually one of the safest places in the world to give birth. There are definitely ways in which our maternal healthcare system could improve for all women overall, but I do have to say it's quite safe. But according to a recent Save the Children report, the UK ranks 24th in the world for quality of maternity care, which is actually quite disgraceful given that we are the fifth largest economy in the world. It really needs to be better for women overall. But to make that even worse, the experience of black women in maternal health care, I'll tell a really starkly different story. Now, I've said the statistics many times, and I know you have, but I think it's really important to repeat them every time you have the opportunity, because black women in the UK are 4 times more likely to die in pregnancy and childbirth. If you are a black African woman, you are 83% more likely to suffer a near miss during pregnancy. If you are a black Caribbean woman, you are 80% more likely to suffer a near miss. And these near misses can go on to have very other consequences for you in terms of your health. If you are a black lady, you have a 121% increased risk of stillbirth and a 50% increased risk of neonatal death. Miscarriage rates are 40% higher in black women, and black ethnicity is regarded as a high risk factor for miscarriage. Black mothers, especially those from a black Caribbean background, are twice as likely as white British women to give birth in the 37th week of pregnancy. And the situation for women of mixed heritage and Asian women, unfortunately, is not much better. Women of mixed heritage are 3 times more likely to die in pregnancy and childbirth, and Asian women are 2 times more likely. Asian babies have 55% increased risk of stillbirth and a 66% increased risk of neonatal mortality. And for too long, these statistics have all pointed towards a glaring disparity in maternal health experiences, and for too long, nothing was said. And these harrowing statistics should really spur any government or healthcare institution into taking action. But sadly for the government still passing, it really hasn't. This government has been really awful about it. They refuse to take any meaningful action to end disparities. They've suggested some awful things, even inducing black women early, just as a means of getting over this issue, seeing if that would work. And just with all health issues, women's health issues, the government have dragged their feet and refused to invest meaningful time and resources into addressing the issue. They repeatedly refuse to have a target to end racial disparities in maternal health care, and they said there's a lack of data to do this. All of that data I've given you, and they said there's not enough evidence to have a target, and they refuse to take the necessary steps to improve the data and understanding of these disparities. And since the Human Rights Select Committee report in 2020 that brought these disparities very firmly to the government's attention, there's been no government-backed research to look at the experiences of black women in maternal health care, and there's also not even been any more to improve ethnic coding in health records. So how exactly do they intend to reduce racial disparities in maternity care if they're not even going to put any resources into looking into researching this issue? And every time I've raised this issue in Parliament, I've been told over and over that the UK won't remain one of the safest places in the world to give birth. And on the whole, yes, the evidence suggests that, but evidence also suggests that black women and babies in the UK are still dying at a disproportionate rate to women from white backgrounds and babies. And a refusal to take steps to end this is an acceptance of the status quo. I even remember at one point talking about my own experience of stillbirth, and I think I got a figure wrong, and I corrected myself. And when raising the question again with the Equalities Minister, Kemi Badenoch, instead of her addressing my point, she wanted to make the point that I got the figure wrong, talking about perhaps what was the most horrible experience of my life. And in attempting to spend her time correcting me, she got the figure wrong, which shows you just where this government's priorities are. And likewise, when many of my other colleagues face the issue of institutional racism on the whole, in creating these racial disparities, we're told that it doesn't exist. In fact, rather than addressing it, the government commissioned an entire Craig report to say that institutional racism doesn't exist at all. I can tell you confidently, as a woman in this room, that institutional racism very much does exist, and stereotypes about pain and tolerance of black people, our cultural beliefs, our practices, and our perceived understanding of the medical system all contribute to the negative experiences that black women have in maternity services. If we're going to improve maternity services and outcomes for black women, then we have to address these racial stereotypes that cause them. We can't deny institutional racism because it's uncomfortable for us to acknowledge that it's there. The colour of a woman's skin should never impact the experience that she has of maternal health care or the chances of a successful outcome. It shouldn't impact whether or not black babies and Asian babies, maybe mixed heritage, are more likely to come into this world alive or dead. But the sad fact is in the UK, it does. And without further research into why, without plan to actually reduce this gap between in maternal health and health outcomes, without a target to work towards, black maternal health disparities will continue to exist and be yet another women's health issue that is not adequately addressed. So I really thank everybody for listening today. And when you do make cases in all your different fields for the increase, for better services when it comes to women's health overall, I really appeal to you to make a case for improved experiences of black maternal health and improved understanding of black women's health overall. Thank you very much.
Thank you so much, Bill, for that fantastic start to our discussion. You've raised some really vital points on black maternity mortality. Now, on black maternal mortality, I'm sure that lots of sisters in the room will, have questions. The plan is for us to take questions after all our panelists have actually made their contributions. I'm aware that Bill, she's already leaving. Sorry. Okay, thank you so much, Bill. So I was going to take her questions now since she's leaving, but what we're going to do now is I'm going to invite the rest of the panelists and then we'll have our questions afterwards. I'd like to invite Claire Murphy, the Chief Executive of the British Pregnancy Advisory Service, to make her contribution. Claire.
Thanks, Lucy. That was quite a hard act to follow, like she's gone. So I'm also going to touch on some of the issues around health in pregnancy. But I'm actually going to start with abortion, which is the key service that BPAS delivers. We see 100,000 women a year facing an unplanned pregnancy or a pregnancy that, for whatever reason, they cannot continue. And although in many ways we have made the abortion framework in this country work for women, we're thinking about the role of women's voices and needs and rights in the provision of healthcare today. There is really no greater example of an egregious law than the one we currently have. The 1967 Abortion Act, which, while groundbreaking for its time, did not decriminalise abortion. That remained and today remains a crime under the 1861 Offences Against the Person Act. That law has never been repealed. It remains a crime for any woman today to procure her own miscarriage. And abortion is only legal if a woman has the permission, authorisation, legal authorisation of two doctors. It is not about a woman's right to end a pregnancy. There is no right to end a pregnancy in this country. And while, as I say, organisations like BPAS and many wonderful doctors in the NHS have made abortion services work well for women, the fact that this still sits in the criminal law is a problem. It's a problem for the delivery of services, and it's a problem of principle. And the political scrutiny that abortion still gets, and the fact that it is a politicised issue, means that a little earlier this year, the Health Secretary was on the brink of withdrawing women's right to access safe, effective, early medical abortion pills at home because he had an ideological opposition to abortion, and that was only overturned by a parliamentary vote on which Labour MPs really stood up and were counted on this, and they made absolutely sure that women retain that right to access that service in this way. This was something that was developed during the pandemic. It's a safe, effective way of having an early medical abortion, and one that women should absolutely have access to. But ultimately, we will only see this politicisation of abortion reducing if we are able to decriminalise abortion, and that means overturning this, really offensive section of the Offences Against the Person Act to really make very clear that having an abortion is not a crime. We want to see abortion decriminalised, taken out of the criminal law, and regulated in the same way as any other healthcare procedure with number of other areas in women's healthcare where we also see these kind of barriers put in place, where women's reproductive choice is subject to a scrutiny and a supervision that you would not see in any other area of healthcare. Access to emergency contraception actually is another case in point. There is simply no clinical reason why a woman cannot just go into a pharmacy and buy what is a very safe, effective pill to help her avoid an unplanned pregnancy without having to have a lengthy consultation about the reasons that she needs that. In many countries, emergency contraception is available to buy straight from the shelf, and it absolutely should be the case here. And again, it feels to me that's another example of where we've put barriers in the way of women in order to police some of their behaviour. One thing that I also wanted to touch on, and an area that I think is I'm growing in concern about in terms of medication and women, is the increasing restrictions that we're also starting to see on women's access to medications on the basis of their capacity for pregnancy. We're seeing increasing restrictions on access to medications such as sodium valproate, which is a really integral medication for women who suffer from epilepsy. There are all sorts of reasons why women need to know that if they were to get pregnant while taking sodium valproate, that it's teratogen. It may harm their fetus. But what we're starting to see is real barriers to women being able, any woman of reproductive age, being able to access that medication in the first place. So that is a restriction being placed on women's access to medication based solely on their capacity for pregnancy. And in pregnancy itself, we've got this kind of position that nothing is safe in pregnancy, and ultimately what ends up happening is that women are denied drugs in pregnancy that are actually really important for their continuing health. We know that women, say for example, suffering from hyperemesis in pregnancy, very severe sickness, can sometimes struggle to get the medications that they need. And this message that we have continually pushed forward around nothing is safe in pregnancy has also, I'm afraid, I think, led to some of the reservations that we saw, say, around the COVID vaccine last year, when we tried to that was rolled out as to pregnant women after some initial very mixed messages around it. But by the time it was advocated that pregnant women should take this, many were very, very reluctant, partly because of this narrative we've always had that women need to be extra careful in pregnancy. And of course they do, but they also need good information and evidence that enables them to really value their own health needs. And sometimes we're just not doing that very well. And I think it's really important that we listen to women's voices, but also that we recognise women have their own health needs in pregnancy, and those are not mutually exclusive from those of their fetuses, and that pregnancies thrive and survive when we take women's own health needs, women's voices, when we listen to those voices, where we give women the evidence and information to make the decisions that are right for them. And as Lisa said, our strapline is we trust women, and we trust women to make good decisions based on the evidence, based on what is right for them.
Thank you so much, Claire, for those really important words on our bodies and our reproductive rights. I've really learned so much so far. And sisters, please don't forget, if anything you've heard so far resonates with you, please tweet it and use the hashtags as well. Next is Taiwo Owatimi, MP for Coventry Northwest.
Thank you, Missy, and hello everyone. It is an absolute pleasure to be part of today's panel, and also to follow after Claire. Claire really does touch on some important points. As a pharmacist, I never understood why we were asking patients questions before we were giving them emergency contraception, because in most cases people are aware of what medication they're taking and the risk factors that are involved with those medications and how rare they can be. So today I just really want to focus on the women's health strategy, my particular views on it, and covering areas around endometriosis, PCOS, menstrual health, but also research and development, which was really an opportunity in which the women's health strategy failed to truly deliver. So we waited a year for the women's health strategy, and everybody was really optimistic. We had Westminster Hall debates, meeting with ministers, all presenting our concerns, the many women that we've spoken to said that we needed to be addressed, but also actively saying to the government that we really want to work with you on this because 50% of the population have been let down and they shouldn't be left down. So on the day in which the women's health strategy was announced, I remember I and my team was rushing around going, oh wow, this is actually here, let's go through the document. And as we started going through the document that evening, it became really apparent to realise that it was actually an absolute disappointment. What they did was basically all their old announcements, they put it together in a document and put women's health strategy on it. And then they also looked at different departments and made commitment into various areas that affected women and said, okay, that's got the word women in it, put it in the women's health strategy, and voila, we've got such a wonderful document, that everyone's going to like. And when I look at that strategy, I felt really angry and really frustrated because the one thing that I heard from women in my constituency and through the various panels I was doing was that first of all, women wanted to be listened to. Secondly, was that women wanted us to understand that there were regional inequalities, there were disparities between the way the services were commissioned across the country. Now, when you look at the women's health strategy, most of the people that responded back to the consultation the government did were people from the South and London, which is all fine, but that doesn't represent the rest of the country. So again, it didn't meet the needs that women were talking about. For patients with endometriosis, I'm not sure how many of you know about endometriosis, but it is a condition that really does affect a large amount of women. And the amount of women that suffer from endometriosis are in the millions, and they're about approximately the same number of those who are suffering from well-known conditions such as asthma and conditions such as diabetes. However, we do not have a proper strategy on how we're going to address endometriosis. Now, 63% of the women that go to see their doctors say that when they express to their doctors that they're going through pain, no one listens to them, they're absolutely dismissed. They have to go through 10 different appointments until somebody goes, oh, I think I know what you're doing. I think I learned that in medical school. I saw a patient 20 years ago. I think you might have endometriosis. That's 10 appointments, 10 GP appointments, which we cannot offer in our society because it takes ages to get a GP appointment. So women cannot be able to wait. During the pandemic, we also noticed that a lot of women with endometriosis and a condition such as fibroid kept complaining about the pain and how debilitating their conditions were and the lack of support they were getting. And it became really apparent that what had happened was that when the Royal College of Surgery was deciding how, Obs and Gynae were deciding how they were going to prioritise surgery and how they were going to prioritise what conditions they were going to operate on, endometriosis wasn't on that. And why was that? They used pretty much one clear criteria, which was that it had to be an urgent surgery in order for them to be able to carry out that particular operation. Now, if any of you are aware of endometriosis significantly affects women's life. It is excruciating, debilitating pain, but also it can cause irreversible loss of fertility. So for anyone to think that endometriosis surgery is not urgent just shows how, first of all, the medical industry does not understand women's health, but secondly, no one is listening to women and nobody understands the priorities that women want to be number one on their agenda. The other thing that we heard a lot from women when I was speaking to women across the country was that there was a lack of diagnostic research, both into endometriosis and into PCOS. And again, when you look at the amount of women that suffer from endometriosis and PCOS, it makes absolutely no sense that we're not getting that research dedicated into trying to find out what are the causes of this condition and how best we can address it. Now, the Women's Health Strategy was an opportunity actually to say, okay, we know in the long term we don't have the research to be able to explain why this condition is not happening, but actually we know that we can provide practical advice to women. So that means that we know that women that suffer from endometriosis and PCOS over the long term, due to the pain that they go through, more likely to suffer from mental health conditions. How are we going to ensure that we provide them with that support during that time? We know that it's going to significantly impact people's jobs. For young children, it's going to affect their ability when they're in school. Practical advice, how are we going to ensure that not only for the economy, because it's taken away about £6 billion from our economy, but actually that we provide the right legislation to support these women so that they are able to be effective in their workplaces, but also that they're able to focus on their education. The Women's Health Strategy also missed the opportunity to be able to really hold organisations into account. So, for example, NICE hasn't developed PCOS guidelines. Now, I do not understand why that is, given the fact that it affects so many women, and NICE is aware that it is a medical condition that many healthcare professionals have been asking for guidelines about. There was nothing in that strategy that really enforced NICE to do that. And again, that was a missed opportunity that many women really wanted to see. Now, I want to quickly talk about menstruation because I am aware of time and I'm just trying to speak as quickly as possible. Menstrual health is something that, we all experience menstruation differently. But the reality is that for some women, menstruation can be very, very difficult. And menstruation can really have an impact on their ability to function. And I'm going to even just admit to say that on Saturday night, I was having that discussion of, would I have the energy to come down to conference because I was in so much pain and I had to really adjust my diary for me to be here. And the Women's Health Strategy should have been an opportunity for us to talk about how we are going to support women across the country who are dealing with it. And again, this was a missed opportunity. There was a lot of focus on how we were going to give women, young girls, the education in schools, which is really important. However, there was no conversation about how we're going to start giving them practical advice, how we were actually going to put that within the education system, and also empower schools, employers, and people who relate with women on a daily basis to really understand the complications that can come up with menstruation. Again, no support was given for that from the Women's Health Strategy. Now, like I said earlier, when it comes to menstruation, women lose about 9.3 days per year due to symptoms related to menstruation. So that means that in our country, we are losing a large amount of our workforce for nearly 2 weeks because we're not providing them with the support to deal with menstrual health. And then we have to have a policy on how we are going to address menstrual-related symptoms, because without that policy, economically, it just makes no sense. And I know that within the Labour Party, we're working on a new deal to not only talk about how we are going to bring that fund, how we're going to increase statutory sick pay, but also how we're going to support small, medium-sized businesses to ensure that we've got flexible working practices and to encourage them to support women who are going through menstrual pain. And I just really want to touch on something, because whenever we talk about flexible workplace practices, people often want to talk about how we can all work online. And most women's traditional jobs, and I'm sorry to say this, but tends to be in sectors such as cleaning, in sectors such as care, you can't work from home in those sectors. So online working, it is not a solution. We need to actually create policies that are better, that's going to support these women when they're going through this difficult time. And lastly, because I am aware of time, no one has told me to stop yet. I want to talk about research and development because it's a bugbear of mine, and it was the number one ask that I wanted to see in the Women's Health Strategy. And what I actually genuinely believe is that I'm a cancer pharmacist. Cancer research is ring-fenced. It's ring-fenced. You cannot touch that. Researchers know that they can go, regardless of whichever area of cancer it is, they are going to get that funding within that area. Women's health, you do not have that. And the Women's Health Strategy just clearly said, we're going to encourage more people to take on research. I am a scientist, and the one thing that I know is that every scientist wants to be able to create research that is going to get them into some kind of nice journal, or that's going to, get them the Nobel Prize. They do not want to focus on women's health, because I'm going to be honest to say that it is not sexy. So what we need is to actually create a women's health strategy research budget that is ring-fenced and that supports researchers to look into every single area of women's health. We need a dedicated agency. But also, we need to start talking about how we ensure that women are involved in more clinical trials. Now, women are more likely to suffer from health disease. Again, I'm a pharmacist. As a pharmacist, we know that medication affects people sometimes based on their gender, sometimes based on their ethnicity. But there is no women representation in clinical trials is not at the level it needs to be for us to start talking about how do we personalise and tailor women's health and treatments in common diseases like cardiovascular problem. That needs to be addressed. We also need to talk about the fact that women experience more adverse drug reactions than men. I don't understand why NICE and other key government agencies are not collecting the data needed to understand why this is. Have I got time? Yes? Okay. All right. I will be very quick. We've heard from many panels today about the impacts in which they felt when they're pregnant, and there's one area that during the pandemic it really got to me, which was the fact that a lot of pregnant women were dying. And they were dying because we couldn't give them COVID-19 vaccinations. Now, I'm a pharmacist, and the one thing we learn in pharmacy school is when a patient is pregnant, you can only give them paracetamol and then give them water and tell them, that is it, I'm sorry, we've got no medication for you. And that has been it just was normal to say that. And I used to wonder, how is that a plan? How is that a plan? 50% of our population is pregnant, and all we're going to say is, I hope that you get better, I hope it's not a proper complication, but we haven't got any research to tell us what's happening when you are pregnant. That needs to be addressed. And that's what we need to see within the women's health strategy, or proper women's health strategy. I also want to talk about Alzheimer's quickly, because Alzheimer's and dementia is the leading cause of death for women in the United Kingdom. Women over 60 are twice as likely to develop Alzheimer's disease than develop breast cancer. And yet we don't have the data to understand why that is significantly affecting women. We need that data, we need to be able to do that research, and we need that funding to ensure that we're addressing these key issues. Thank you everybody for listening, and thank you for allowing me to go over my time just a bit. So,
Thank you so much, Tyrone. You've dropped lots of gems. You mentioned about mental health, about the women's health, and endometriosis. I actually love the fact that you mentioned this particular condition, which in my opinion is really one of the most almost undiagnosed or least known about condition that affects many women, even fibroid as well. And it's really interesting that you really enlightened us on the gaps that exist in healthcare, and also the solutions were really useful points as well. Thank you so much, Tyrone. And next is Elizabeth Carr Ellis, the Menopause campaigner. Thank you.
Thank you everybody. It's a bit of a shock to be here, to be honest, amongst such an eminent panelists. But yeah, you should all have one of these, or two of these, on your desk. This is my creation, this is my baby, please put it with care. This began 7 years ago, and thinking back, I think, oh my God, 7 years ago. This began 7 years ago when I looked at a photograph of myself, and Glenda Jackson, this Elizabeth I, looked back. I thought, who is that woman who's gone bald? Because that's not me. So I went off to the doctor, and I said, I'm losing my hair. And she went, yes, you've got male pattern baldness. We'll do a test for you, see if your iron levels are okay, and then we'll send you on your way. My iron levels were fine, my hair continued to fall out and recede, but there was nothing I could do about it. A few months later, I was back at the GP's because I was woke up in the middle of the night with the most excruciating pains in my joints. They gave me some vitamin D and sent me on my way. A few months later, I was back at the GP because I was getting palpitations. They sent me for a heart test to make sure my heart was okay. At the time, I was running for the Great North Run. I was training, fittest I'd ever been. But that made no difference. I got sent on the heart test and done that. I also, at the time, started developing anxiety and depression. I worked next to the Thames. I used to walk down to the Thames at lunchtime and wonder if it would really hurt to throw myself in. because I couldn't see any point in living anymore some days. I would get so angry at my husband because he breathed. My husband can breathe at times. And I would get so angry and I would try and kill him with a tea towel. I'm an expert tea towel flicking. I can kill anybody with a tea towel now. I have had so much practice. All while this was going on, these palpitations kept going. And one day, the anxiety got so much that I went to A&E because I was convinced I was having a heart attack. I went in and 4 hours later he told me I was as fit as a fiddle and to go home. I started crying and I said, I'm so sorry I've wasted so much of your time and so much of the NHS's money. And he said, can I ask you a personal question? So there I am, 50 years old, palpitations, crying, saying I couldn't see any point of living. I was too upset to talk. And I said, yes, what's your personal question? He asked me if I'd taken cocaine. A few months later, I started getting hot flushes. By this point, I wouldn't go to the GP anymore. Every time I went, I was given a blood test, or told there was nothing they could do, told the blood test was fine, or I was given a prescription for drugs. I dealt with one symptom, and then another one came. So I refused to go to the GP. My husband, bless him, decided, because he's a man, he was going to fix me. He was going to fix me by looking at some natural remedies if I were to go to the GP. And he looked, and after 5 minutes on the internet, he said, do you realise everything you have been through over the last 4 years is because you're going through the menopause? No, I said, I'm just, periods are irregular, that's fantastic, I don't have to worry every month. I can wear white every now and then, it's brilliant. And I just got hot flushes, that's it. And he says, no, have a look. And there it was on the NHS's site. Everything I'd been through was menopause. I went to the GP the next day, and he printed out 4 sheets of A4, telling me about the menopause. It was everything I'd read the night before. I didn't need those 4 sheets of A4 at that time. I needed those 4 sheets of A4 4 years ago when I first started menopause. So I started getting annoyed, and menopause rage can be a fantastic thing because one night I was sitting at the GPs looking at all these posters, looking at all of the wonderful posters they have for a variety of things, and thinking, apart from childbirth, there's absolutely bugger all for women on there. And there's certainly nothing for the one condition that every woman is going to go through. Not one indication. I'm a journalist. I'm a woman. I get sent all the boring women's stories. Never once had I read about menopause. I had no idea about it. The place I should have found it out was at my GP's, and there was nothing. He didn't diagnose me. My husband diagnosed me. So I sat there and I thought, right, the bloody NHS will give us a poster, I'm going to give us a poster, which is how I began the Positivity Know Your Menopause campaign. I'm not going to say this is a brilliant campaign, but this is a bloody brilliant campaign. And I never realised that until a week after we first did it. The plan was very simple. I gathered a group of amazing women around me, and on the 1st of July, 3 years ago, so 2019 is that? Yes, 3 years ago, we all did selfies with this poster. None of us slept the night before thinking we were going to be the biggest hits in the world the next day. But we did this. By the end of the week, the poster had been downloaded so many times we've lost count. We had GPs sending us thanks to say, this is what my patients need. We had celebrity doctors doing it. We had Jeremy Vine hosting a poster with us. We have gone around the world. We've inspired campaigns in America. We have got an Urdu version, which has been used to help menopause research in Pakistan. That is one of my proudest achievements. I love it. And today, we now have a one in Polish to help all the women over here who speak Polish. English. We have 8 languages plus an accessible one. NHS England says there is no need for any menopause posters whenever we have approached them. Not one of them has picked it up. They say they have no plans for any public health campaign, despite the unknown going. Women in the 45 to 54 year age group are at the biggest risk of suicide. I had to have 3 amazing women in my job talk me out, throw myself under a train one day. That's not easy to say, but it's the truth. And the more I say it, the more I get women coming up to me saying, that is how I felt. Women take out posters to the GP because it is the only way they can show that GP that they are menopausal. It is a way that they can juggle the dots between everything that they've been going through. And it's not just us. I know women who have gone through menopause and they're 14 and 15, and they have felt so alone and so scared. If they had seen a simple poster in an NHS office, they would know they weren't alone. They would know other women did it. Everybody says, I feel alone, I feel scared, I feel bereft. Women are leaving work because of this. 1 in 10 menopausal women will leave work. 1 in 4 will think about it. How much experience, how many fabulous role models are we losing because of this? I was turning down promotions. I broke the glass ceiling when I was in my 30s. I became my newspaper's first ever female night editor in 187 years of its history. I went away, had a career change, came back, and certainly I couldn't even do jobs that I had been doing in my 20s because I was so scared and so nervous because of that. We have some amazing campaigns going on. We have a workplace menopause pledge. But the one thing I want the Labour Party to take away from this is pledges aren't enough. My employment is fantastic. I am still too scared to say I had no sleep last night. I need some time off. I can't do that. And I have the most amazing employer who is very menopause aware. But for me, I can't do that because I have no protection in law. So the one thing I want the Labour Party to take away is menopausal women are not going to go away. We're going to get stronger and we're going to get louder. And we need the politicians to hear us and to listen to us. We don't need menopausals that come and go in a matter of weeks. We need someone to sort out the HRT shortages. 4 years ago, I appeared on the BBC talking about HRT shortages. Every month since then, I've had women contact me to say they couldn't get the HRT. The latest one that we got the headlines a few months ago, for me, I got so angry because I thought that this is just the latest one and it's going to make the headlines and then it's going to be forgotten about. With your sisters, we're not going to be forgotten about. Every one of you is going to go through menopause if you're not already. I don't want anybody walking down to the Thames and thinking they would be better off throwing themselves in. I want everybody to have a good menopause, and that's why I'm in this panel tonight, and that's why I thank you all for your time.
Wow. I'm almost speechless, to be honest, because I was just so moved by your words. Thank you so much, Elizabeth. Thank you for sharing those powerful words with us, your lived experiences, and that really touched my heart, and I'm sure they had so many sisters in the audience. The fantastic work that you're doing with your menopause campaign is so important. Next, I will be taking Ashley, and after Ashley, I will be introducing Dr. Rosanna Ali Khan, and then we'll be having questions. I know, very exciting. She's just arrived. So Ashley is a cancer survivor, a 2-time parliamentary candidate, and a fantastic, brilliant LWN exec. Ashley, please.
Thank you, Lisa. So we've had, the title of today was from menopause to mental health to maternity.
and I'm doing memories. So there's another in there. When LWN asked me to come along and speak today about my experience as a woman going through breast cancer treatment, I was reflecting on my treatment, which was about 9 years ago now. I was diagnosed at the end of 2013. And this theme kept coming back to me, all the things that jumped out as part of that experience gave me this theme. And that theme I have heard every single woman on this panel speak about tonight. And that is that women are not listened to. And I want to share a few bits of my story to hopefully shine a little bit of light onto what that actually means in practice and what it means to us as women. So, I was diagnosed with breast cancer. It is the most prevalent cancer in women in the UK, and 1 in 2 of us will have cancer at some point in our life at the moment. So statistically speaking, it's something that is going to affect a lot of women. I went to my GP with a lot when I was 38. I was told I was too young to have breast cancer, and I wasn't diagnosed with it until the end of 2013, when I was 41. It is miraculous that I am still here, quite frankly. I didn't do anything, it's just the way it went. But what struck me was the fact that they didn't listen to the fact that I knew something was wrong. The lump was too small, they said, for me to know that it was breast cancer. I didn't know it was breast cancer, but I did know it wasn't how my breast normally feels. It wasn't right for me. And we are told over and over and over again that early diagnosis is the most crucial thing in tackling cancer. Well, sisters, it's all well and good being told that, but when you go to your GP, when you go to a consultant, and they palm you off with, no, you're too young for it, love, it doesn't matter how early you've gone to raise the alarm. But then as my cancer treatment went forward, we didn't know initially whether or not it was going to be curable or not, but it looked like it might be. So they gave me chemotherapy. Great, I'm one of those people. I was not, it was devastating to get a diagnosis. As soon as I got a plan, I thought, right, we've got this. We've got a plan, we're going to work through it. So I went to start my chemotherapy. I had it before surgery. And I laugh about this because it's hilarious with me. I went in to talk about what chemo would mean, what they were going to do, what drugs I was going to get, and what these side effects might be. And of course I knew that I was probably going to lose my hair, wasn't really a problem for me. I was like, well, it's hair, it'll grow back. There was all sorts of things that I knew about. And one of the things that I did know, was particularly at my age of 41, is that it's highly possible that chemotherapy can kill off my reproductive system, and that my ovaries will stop working, that I wouldn't be able to get pregnant again. And the junior consultant, the oncologist, asked me 7 times if I wanted to freeze my eggs. 7 times I told her that I did not, that I was 41, that I had a 14-year-old daughter, my family was complete, and I was not interested in having another child. Well, you might change your mind, she said. So, okay, shall I say it again? I'm not interested, I don't want to do that. 7 times. Now, in the end, my wife was sitting next to me, so my wife was my letter.
I'm happy with that.
My wife was sitting next to me, and I literally had to say to the doctor, look, if we need any eggs, we'll use Rachel's. And that was the only way I could get them to shut up, because they could not hear me. Then after I had my mastectomy, the surgery was amazing, but after I had my mastectomy, they insisted that I go and speak to somebody about reconstruction. I said that I didn't want to rush into reconstruction. Didn't want it immediately after my mastectomy because, you know what, there's a lot going on. And I wanted to just really focus on doing the bits of things that were going to save my life potentially, and I was going to worry about the rest of it later. Oh, it'd be a lot easier if you did it now. Easier for who? Who's it going to be easier for? I had 3 meetings with consultants who told me that I wanted reconstruction, how they were doing reconstruction. 3 times I said, that's not something I'm ready for yet. At the last meeting that I went to, I was told that if I didn't hurry up and make a decision to have reconstruction, it might not be available in the NHS soon. I felt like I was being bullied into having a breast put back on. Well, here's the interesting thing. When you then go to the next phase, I mean, I am happy what we call uni-goober in our world. I have one breast and I usually wear a prosthesis in the other one. But there's a lot of women, they're not happy with that and they'd like to have surgery for symmetry. And it's something that I have considered, which essentially means removing the other breast so that you have a symmetrical shape. It is almost impossible to get access to that surgery. In order to have access to that surgery, you have to undertake several psychiatric assessments to ensure that having that breast removed is going to improve your mental health, even if you ask for it over and over again. So they were quite happy to undertake significant surgery to remove a large part of my belly and then do complicated vascular surgery to stick it on my chest and make a pretend breast out of it. But they didn't want to take this one off to give me the surgery. And what it says to me, the stuff about chemo and my eggs, the stuff about reconstruction of my breast, and then the refusal to remove my healthy breast, is that if you make a decision as a woman which does not reflect what society thinks women are for, they will not believe you. They will decide that you do not know your own mind, that you will regret it, and that you need to be talked out of it. When I wasn't talked out of it, I still don't have a real breast on the side. You know what? It's absolutely fine. I haven't suffered any ill effects. Having said that, I know lots of women that have been through reconstruction, and that works for them. Because what's important isn't that we all make the right choices. It isn't right or wrong to have reconstruction. It's not right or wrong to not. But it is wrong to not listen to women and understand that we're all going to make different choices, and we know what choice is right for us. But I did want to finish on a kind of more upbeat tone. Because when we talk about breast cancer, quite a lot of the time, it seems a little bit miserable. It's not a very, it's not a happy subject. But my cancer journey really opened my eyes in terms of what the NHS under the Tories is able to do. Because it wasn't medical professionals that were being, that they were being lazy or neglectful that caused my late diagnosis. It was an under-resourced and overstretched NHS that the Tories have allowed to become so desperate that people are rushing through and don't have time to make the decisions that they really like to make. It's a Tory underfunding of the NHS that means that they don't have time to sit and listen and talk with women and give women the support they need to have proper conversations and make their decisions and stick to them. And it was that experience that really motivated me. So having been through chemo in 2014, having had a mastectomy, spent a whole year basically having treatment, I decided to come back to Labour Party, and I'd had a bit of hiatus. I was raising a child and having a job. But I came back to the Labour Party and I found LWN. And I came back to office here in Liverpool in 2016, and LWN gave me the confidence to believe that I since my diagnosis, I've stood for Parliament twice. I am cancer voice for women, and I will continue to come and I will continue to speak up for women, but more importantly, to encourage other women to speak up for yourselves.
Thank you so much, Ashley, for sharing your lived experience with us. I'm sure that many sisters in the house, want to ask questions straight away, but we need to take 5-minute contribution from Dr. Rosanna Ali Khan. I was really excited when she came in. I'm sure that many of you will remember that viral Love Actually scene that she recreated in one of her campaigns, which was absolutely fabulous. Dr. Rosanna Ali Khan has been an MP for Tooting since 2016. Before politics, a medical career also took her overseas as a humanitarian doctor, supporting efforts in some of the biggest humanitarian crises in the Middle East, Africa, and Asia, and she still works shifts in the accident and emergency. Thank you so much, Dr. Rosanna, for coming. We'll have a contribution.
Thank you. What an honour it is to be here, sisters and brothers. Thank you so much for the introductions. Sometimes I listen to that and I feel tired listening to it. But I tell you what, us women, we have energy, we have unparalleled energy to get on and do stuff. And yes, I'm here as a member of Parliament, and yes, I'm here as a shadow cabinet minister for mental health. But I'm also here as a woman, and I'm here as a mother, and I'm here as a sister. And all of these things are really important because underpinning everything that we do is the strength of resolve we have to find as women to fight harder than anyone else does to get exactly the same thing that would be afforded to men very easily. And actually, in my career as a doctor, as well as in my career as a politician, I've never seen it so stark as in health. And 18 months ago, the government presented their big statement on their Women's Health Plan, their Women's Health Strategy. And I responded to that with my input, the Labour Party input. 18 months later, where are we? We're no further on. And I love the fact that their big announcement was a call for evidence. I'm sorry, what? A call for evidence for women's experiences. We've only been married on to tell you about our experience for the past 50 years. What do you call bloody evidence for? You've got plenty of evidence. And I'm also a proud supporter of the Menopause campaign. I've been one of those people standing there with the poster. And I love that you've got it translated into Polish and Urdu because I'm Polish and Pakistani. How could you put it in all languages? But quite frankly, getting to the serious points now, when we look at medical textbooks and symptoms are written down, when you study at medical school for how certain illnesses and diseases present, they're written according to men's symptoms. How many of you put your hand up if you know that for women, a heart attack can present with a tummy ache? And I know that. So all the posters that we have of the man within his chest, the belt across his chest, tell us, oh yes, if you feel the pain across your chest and the tightness across your chest, go to A&E, you might be having a heart attack. Well, that's great, but what about the picture of the woman having a tummy swell? Go to A&E. And in textbooks, symptoms are written down mostly according to men's symptoms. We also know that when we are studying
Under quite a lot of pressure to wrap it up, unfortunately, because they need the room. You're doing an amazing job. Can I just ask for 3 lightning quick questions, but we don't have time for the panel to respond. Just give them one sentence of concluding thoughts each. We just take questions. Yeah. 3 quick questions. Take them all at once, really quickly. If people start making speeches, cut them off. Then give the panel 1 sentence each to respond with a concluding thought. They can't respond to each of them individually. Thank everybody for coming. Encourage them to take a drink and take the networking outside into the Galleria area. Like literally, they want us out. Yes. Can you apologise for the room mess up and tell them to keep networking with a drink outside? Thank everybody.
By the time we come out, do people even realise what it takes for us to take that step to go and ask for help? When we go and ask for help, we don't want to get shut down. And there's certain times in your life where there's a bit of hormone sensitivity, like if you just had a baby, you know, you get asked about your feelings sometimes if you have a good relationship with your wife. And you almost have permission then to say that you're struggling. Because, oh, yeah, got diagnosis, brilliant, get protein depression, great, got something. What happens if your child is 5? What if your child is 5 and you can't sleep? And you're starting to feel really down? You don't feel like getting out of bed? Or drinking a bit more than you think you should be drinking. You wake up in the morning, you actually reach for a drink and you have got a problem. What happens then when you go to a GP and you tell them how you feel and you get told, don't worry, just try and get a bit more sleep and you'll be fine? That's the reality of which we're facing. And maternity. We know maternity care, the absolute devastating stats that we know about mortality rates of black women. We've got all the data. We have debates in Parliament. Taiwo, my friend, is absolutely an incredible campaigner for all things related to women's health, black women's mental health and maternal mortality as well. But we have the stats, so why isn't someone doing anything about it? It's not just enough to have the data, we have to act. And that is where Labour Women's Network is a powerful force. Because we come together and we understand that in our solidarity, we are a powerful force for campaigning and for change. And menopause, I had a little radio show for a while called Mental Health Matters, and we did a whole hour on menopause. What was it? We had a whole hour on menopause. So there was talker, it's definitely Polish starting heritage. Leaders and daughters. And we had a whole hour on menopause, and the thing that came across, the thing that we want tonight, is not feeling listened to. And I'll just end by saying my own childbirth experience was pretty horrendous. And as a clinician, and as someone who's articulate, I still didn't feel that my needs
No questions, one completed sentence each. I'll encourage everyone to chat to the speakers. No questions, one concluding sentence, not a minute from each.
So we absolutely stand
Encourage
together.
everybody to take a drink and walk outside and ask questions of the speakers who are able to stand outside.
Keeping on and understanding that together, us women are an incredibly powerful force. So let's go out